Okay, so pediatric emergencies, what we just covered in the last chapter. So this is geriatric emergencies, the other end of the spectrum. And so as we go through this, there's a number of things we're going to have to discuss too, just like we did with the pediatrics. Um, there's just different ways that we handle them. Mistreatment and abuse is part of it, and a little bit of Alzheimer's. I'm going to try to upload the video to this. I can't show it in class, but I think I can upload it, and we're going to give that a shot. And basically just discussing geriatrics. This is a quicker chapter. So age-related changes after age 30, and you're going to need to know that for tests. I remember that very specifically, that question. After age 30, organ systems lose 1% of function each year. So I'm going on 40 here next month, actually, less than a couple weeks away. I'll be 40, and that means for the last decade, each organ system in my body has lost 1% each year. So over the last decade, I've lost 10% uh, function each year. And that's a sad fact, people. So maximum heart rate declines, and then older patients with internal bleeding will not exhibit heart um, rate as rapid as expected. So again, older patients with internal bleeding will not exhibit heart rate as rapid as expected. So as a young man like myself, even though I've lost 10% functions in the last decade, 40 is still considered young, 30, 20, whatever. So rapid, when we have bleeding internally, we go tachycardic because our heart rate is trying to compensate and pump that blood through our body and perfuse our body and drop, bad oxygen off at the lungs and good oxygen carried to the body to perfuse it. And so with all that said is with older patients, you will not see that tachycardic as you would in a younger patient. So internal bleeding does not always exhibit the same way as it does with us. If unaware, EMT may miss that older patient is in shock. So when we don't recognize the shock symptoms that we've been teaching for 33 chapters roughly, tachycardic with hypotension, we can miss that with older generation because with the geriatric patients because they don't exhibit the same. So you have to look and use your common sense and more, more than you do vitals. You look at the mechanism of injury, you look at how they're feeling, how they're looking, all that kind of stuff, and help make judgment calls. When you're communicating with these older patients, it's kind of like going back to the pediatric causes of patients' communication difficulties. They change in their hearing and vision, memory, and memory and attention. So part of what I mean by that is I've had patients in the back of the ambulance. I did a transfer one time with an elderly patient, well in her 90s, I believe, um, holding the conversation with me all the way to Denver. But yeah, at the same time, she couldn't hear anything I was saying, and she was blind. So she was deaf and blind. And it was really difficult to communicate with her because you want to explain what you're getting ready to do. I'm going to check your vitals. She doesn't hear you, she can't see you. So you got to really be careful with how you communicate. Residual effects of stroke or dementia often can happen if they had a stroke a decade ago and they're still suffering from it. Dementia and Alzheimer's, which we're going to get to in a minute, it's just a horrible deal because one minute that person may know you and talk to you, and then at the same time, an hour later, not recognize you and be resistant and ornery. They just change on a dime, and it can be difficult at times. I had one lady, a funny story is I had a lady one time I was visiting as a pastor, not as EMS, but as a pastor at the nursing home. She thought I was somebody else for a good 30 minutes of the conversation, and finally she asked, and I tried telling her, no, this is who I am. No, 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 you're just messing with me. You're just messing with me. Your name is Juan or something. I can't remember. It was a weird name. And I'm like, no, no. And she, yeah, you're just messing. You're a funny guy, funny guy. 30 minutes later, she finally asked me how my kids are. But what I mean by the kids is they ain't my kids. She thought it was somebody else, so she's asking me about somebody else's. It was a confusing process, and finally shit dawned on her. But that can happen. You could be halfway through en route to the hospital, and they forget everything that just happened and what's going on, and be scared. So you got to first assume altered mental status as a result of present injury or illness. So you can't let that age and that dementia distract you from the fact there might actually be a head injury or an illness that's affecting it as well. So again, go back to the basics of everything. Nothing changes in the way that we conduct our business as EMS. We still do the sample, the OPQRST, the head to toe assessment, primary, secondary, all that, vital signs. We do everything normal and don't assume anything just because of their age. Um, so always try to communicate, with the older patient. Rather than asking others about her, which is easier to do, it's easier to ask people around, family members, um, histories and all that kind of stuff. But communicate with her or him because they're your patient. They deserve respect. And what I hate it when I see EMS people treat elderly patients horribly just because in the city, for example, those patients are just cattle, moving them through business, business, business as usual. When the reality is that person deserves our respect, deserves our treatment, deserves our honor. You got someone there that's at the end of their life potentially. They went to high school, they went to college, they got a career, they got married, they raised kids, they went to war, they did all these things. They got a whole life behind them. And I hate when people don't respect that just because it's hard to communicate. So do the best that you can to communicate with them. History and assessment of older adult patients. Seeing size up and safety as usual. Look inside and outside residents for clues to physical and mental abilities. Um, look around. See what could be causing. Was there trauma? Did they fall down the porch? Did they trip? Anything could happen. Condition of residents. Man, that's a tough one. Um, there's a particular case right now um, of an elderly patient living in an unkempt environment. Not by abuse, not anything except for the fact that it's just her age, and she doesn't have the ability to take care of themselves. So, condition of residence, you got to look at that. Half-eaten food. Um, are they not eating properly? Did they with dementia? Did they forget that they were eating and now they're starving? House dirty or clean? Items left out that the patient can trip on. Items left out that the patient can trip on. So look around at the residence, make sure it's kept good. Is it safe to get around? Is it not? Is it kept? Is it clean? Is it dirty? Is it smelly? All that stuff. So your primary assessment, again, you form your general impression. Form that general impression. When you walk in a room, are they awake, alert, and oriented? Are they sick, not sick, cyanotic? Are they diaphoretic? Make your assumption or your impression. And then assessing mental status. Hey, Gertrude, I'm here. This is Scout with Cheyenne County Ambulance. I'm here to help you. I don't know why I said Gertrude, except for it sounds like a geriatric patient. Um, but my name is Scout with Cheyenne County Ambulance. I'm here to help you. And can you tell me what happened? Boom, you're checking that mental status. If they talk to you, the airway's open, but assess that airway. If they're not talking to you, open that airway. Make sure they're breathing. Circulation, ABCs. Do they have a pulse? Is it strong, thready, rapid, Brady? Where are they at with that? Identifying priority patients. Are they load and go, stay and play? What's happening? Are they ALS, BLS? Primary assessment done no different than anybody else, except for just like with pediatrics, you do your assessment and then you got to determine is this add their age into it, right? So um, when you're doing that, finding a radial pulse in an older patient is usually no different. I like how they put that in there because the truth is it's in the same spot. Um, and actually, it would probably be a little bit easier because they're skinnier and it's easier to find that pulse. Um, Secondary assessment, so your history, take time needed to get full information, find out whether a patient is compliant with medical advice. So take time needed to get full information. It will take time at times. And then whether a patient is compliant with medical advice. They said to take these pills once a day. Are you doing that? Are you remembering to do that? Because if they forget, it can make a big difference in their outcome. Ask family members, um, again, to confirm the patient's um, condition. So the first thing you want to do necessarily is you want to check with that patient, do the best you can to communicate with them, but then always confirm the information with a family member or bystander that knows them real well. Have they remembered to take their medication? Did the doctor say once a day or twice a day? Um, you know, get that stuff. Do your head to toe exam, vital signs. So if you don't have your vital signs, you don't have trends, right? So get those trends, put them on a 4 lead. You know, um, no matter what their condition is, just get a baseline for their heart rhythmia to give to the hospital as well. Um, Steps of the physical exam. So, head and neck, chest and abdomen, pelvis and extremities, hip and proximal femur commonly fractured and fall. Weakening of bone results in injuries to wrist and proximal humerus. So, again, as you can see in your book, Lady in the Car, right? There's no difference in your exam. Primary assessment, head to toe, chest and abdomen, pelvis, and extremities. Hip and proximal femur are commonly fractured in a fall. So if they wasn't a car wreck, they fell down their stairs, chances are they potentially broke that hip and a femur. Just because things are getting weaker, like we said, body systems they lose 1% a year. So if that's at age 30, now they're 80. That's 50 years of losing body functions in the organ systems. So things get weaker, things get slower, things get harder. Again, remember the medical chapter on this. These patients are also got health issue on top of health issue on top of health issue. So when you're doing your head to toe assessment, you got to remember that they potentially could break their hip and femur. Weakening of bones results in injuries to wrist and proximal humerus. So again, these people might trip just like we would. Accidents happen, but now when they brace themselves to fall, they could break their wrist, they could break their arm. It's just they're weaker. So head to toe assessments really got to be thoroughly done. Um, you know, Same thing, extricating an elderly patient from a motor vehicle. When you're extricating them, head to toe, do your thing, take care of them. Chest and abdomen, a shingles rash often appears as a narrow belt-like around the torso. So again, shingles, it happens in elderly patients more than it happens in my age bracket, but I have heard people in my age bracket having them. So but that's a good picture of one. And I know everybody's running around with chicken pox vaccinations because chicken pox go dormant and then you get shingles later. I don't get caught up in that stuff. Main thing is do a head to toe and take a look at everything if you're suspicious. Steps of physical exam, pelvis and extremities. Check extremities for edema and swelling. So again, CHF. Things are shutting down their body, so fluid retention is common. So check their extremities for edema. Remember, their legs will look like logs. Push your fingers, see if you see an indent. When significant, these can be signs of underlying heart, vascular, or liver disease. So primarily those, yeah, exactly right there. I've seen a lot of CHF patients in the geriatric community. Seen a couple of liver diseases, but more underlying heart. But edema could really mean those issues. So when you're doing your head to toe, I guess the rule of thumb is when you make your primary assessment, when you walk in, you make your judgment call. Um, you got to remember with elderly patients, just do a full exam. Um, I know we typically target our chief complaints, which is great. Do that with them, but also check everything because maybe you went there just because they have a migraine and you find edema in their legs and they have an underlying cause of CHF and they have a migraine because they're not perfusing. So always do a good job with these guys. Steps of the physical exam: spine. Very commonly injured in motor vehicle collisions. Abnormal curvature may make immobilization challenging. So their curvature is a little bit different. These guys, you see them slunch over a little bit. I know one guy in his late 70s, probably early 80s now. His back completely curves to the point where he used to stand up straight, was taller than me. Now he completely is slunched over, nearly just bent over every time he walks and goes anywhere. That's a tough guy to mobilize. So be ready for that. And the cool thing about a vacuum mattress is you don't have to mobilize them flat. Mobilize them where they're comfortable, and a vacuum mattress will secure to their shape, whatever shape you want it. Do best to keep vertebrae in alignment and reduce patient's discomfort. When you do your reassessment, more common for older adults to show a slow, steady decline in condition. Okay, so it is common, does happen. If their heart rate is 70 when you're there, it's possibly going to be getting down to 60 as you're transporting. Maybe 60 is normal to them, and maybe 70 was tachycardic for them. So you may be lulled into a false sense of security. Just like a pediatric, they'll crash and they'll crash fast. Reassess at regular intervals and compare with previous findings. So get all of your primary assessment done, get your baseline vitals, reassess in 5 minutes, and compare notes. Make sure where's your trend going? Better, worse, the same. Reassess mental status again. 1 minute they could be gone, 1 minute they're back. So make sure every 5 minutes that you're checking those things, seeing how they're doing, and then maintain that open airway. Keep their airway going. Reassess, monitor breathing in, out. Are they respiratory rate slow, fast? How's their capnography reading? End tidal volume. Reassess pulse. Is it bradycardic, tachycardic, same? Compare it to the last time you checked vitals. Monitor skin color, temperature, and moisture. Um, Maybe they were in shock, or maybe they weren't in shock when you picked them up, but maybe now they are. So check skin, cool, clam, or cool, warm. You know what I mean. Peak, warm, and dry. Cool and clammy. Reassess vital signs every 5 minutes if it's unstable, and then 15 minutes if it's stable. Typically out here, you're going to get to the hospital fairly soon, so every 5 minutes. Again, we would like to have 3 sets of vitals before you get to the hospital. That's my thing. Do the best that you can to get them, but every 5 minutes I think is suffice. But if you're not worried about them at all and you're making a judgment call, they're not sick, 15 minutes is okay. Ensure that all appropriate care and treatments are being given. Do a good job. Talking with the patient during transport can be therapeutic for them, especially if they're the older, geriatrics. Geriatric patients like to talk. They just like to. They've had an interesting life. They get lonely at times. Their families out, got careers and jobs and lives, and moved on, and they're kind of stagnant. You know, so take time, chat with them, be a friend. I can't tell you. I've said this before, but I can't tell you. You don't ever know. There's times where you take these patients out. You're the last one to take them out of their home that they've lived in, because they may pass away in the hospital. They may never get out. So take time, be respectful. Um, Illness and injury in older patients. So elderly patients prone to some problems because of age-related changes. Again, as you get older, things change. Problems present differently than in younger patients and may present with vague signs or symptoms. I'd say it like this is chances are they're either going to be in your face symptoms or they're going to be vague. Um, so compliance. Some older adults must make the choice between food and expensive medication. Pretty true. I mean, if you look at these patients, man, they lived their whole lives, they worked their whole lives, they got careers and did a great job, served their community in the military, whatever. And then they get out and they get on Social Security. And Social Security, in my experience, is kind of a joke. I don't mean it bad, but it's a joke. My mom worked her whole life. My dad worked his whole life. I know people that work their whole lives and they don't even get enough to survive. So, and their Medicare is not paying out. Maybe they're not being compliant. Whatever. A lot of times these guys do have to choose food, drugs, rent, drugs. Even when a medication is taken, it can have a number of adverse effects. So that's why these guys have a purse full of drugs because they take one drug, it has adverse effects, so they got to take another drug for that side effects of the first drug. Well, then it's a snowball effect. Now they got 100 drugs they're taking, and you're transported in the hospital with a suitcase full of medication. Um, so you got to watch those. Always get their drugs and the history of their drugs. Um, it can occur between or because of inability to clear medications from body as quickly as before. So drug patient interactions. So, makes sense, right? You get put on a drug, it's hard on your liver, it's hard on your body, and over time your body slows down. So now maybe it's not leaving your body quick enough before you take another drug, and it just becomes a problem. And I'm a big believer in drugs for emergencies. I don't believe in staying on them for the rest of your life. I think there's things that we can try to do to help each other out to get past that. Um, but at the same time, not everybody's that way, and that's fine. No judgment. But drugs are hard on the body. It's the bottom line. Blood thinners, you're basically taking rat poison to thin your blood so it won't clot. Do you have to do it so you don't clot and die? Yeah. but you can't tell me that that's good for you either. It may stop the clotting, but what else is that drug causing? So drug interactions, when two drugs interact. So now you're getting on more than one medication, like I said, and they're interacting with each other. Maybe two drugs at the same time is bad, causes a bad problem. And it happens. I've seen this before where one doctor didn't talk to another doctor. This person gets on drugs and they counteract it, or they affect each other, and the person ends up in the hospital. So when you are there with them, find out when they took their drugs, what did they take, how much did they take, and follow and look at the directions from the doctor to see if they're in compliance. Um, Older patients often take multiple medications. I mean, look at that. Look at that. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 18 drugs that they're taking right now. And just right there on their end table, and there's probably more in the bathroom. So, um, like I said, look at those things, read the directions, find out are they in compliance, are they taking care of each other, is there a problem because of them. So when you have a doctor or a patient with shortness of breath, it can result from diseases that cause this symptom in younger patients, such as emphysema or asthma or pulmonary embolism. So it can result from a disease that cause this symptom in younger patients. So, and when you're younger and you have shortness of breath, it can lead to these things. You could have these underlying issues. But when you're older, asthma is a little bit more complicated than when you're young. Or pulmonary embolism, that's not a good thing. Elderly patients more likely to have emphysema or a combination of these diseases. And absolutely true. Elderly patients, they're not necessarily going to have asthma. Asthma is already turned now into emphysema. So again, that alveoli is not producing. It's not functioning. So good or bad air goes in and is not able to drop off the bad gas and pick up good gas and travel the body and perfuse it. So you're having shortness of breath. You're having difficulty. You're not blowing off your end tidal. Your CO2 levels are high. It's just a big deal here. So you got to look at it. And one rule of thumb though with emphysema is you don't want to put them on high flow oxygen because you're going to have an adverse effect. It's not going to help. It's going to make problems. So read your chapter. If there is a section on emphysema, for sure, read on it because emphysema and COPD, more so emphysema than COPD, you want them on low concentration of oxygen. Chief complaint of patient experiencing a cardiac problem. When they're short of breath and having a cardiac problem, it's going to show up in their breathing. Chest pain. Complaint of chest pain can indicate many conditions. Angina, myocardial infarction, pneumonia, and aortic aneurysm. So, this could be with anybody, not just geriatrics. With geriatrics, it's more in your face. But complaint of chest pain, it could be angina, which is a dumb thing that they put there. I mean, that's my opinion, because angina is chest pain. And myocardial infarction, that's a heart attack. That's muscle tissue dying because of a lack of perfusion. And pneumonia, obviously chest pain can cause pneumonia because they're not breathing properly, they're not getting good tidal volume. And then aortic aneurysm, absolutely. If it's geriatric with an aortic aneurysm, that's a bad day. It could be due to adverse effects. To have altered mental status can be adverse effects from medication, hypoglycemia, stroke, sepsis, generalized infection in the bloodstream, hypothermia, pneumonia. You know what? This list can keep going. It's a ridiculous kind of slide, but altered mental status is going to be the same as anybody else, except for typically with a geriatric patient, there's chances they're having adverse effects with their medication, and there's a big chance of hypoglycemia, stroke, sepsis, generalized infection in the bloodstream, hypothermia, and pneumonia. That could give anybody altered mental status. So when you go into these situations with geriatrics, again, talk to them, make your judgment, get your head to toe assessment, get your vital signs for a baseline, and in that baseline, you're going to find out whether they're hypoglycemic or not, and get a list of their medications as part of your sample. Not only get a list of them, get the bottle so you can see the instructions and see if that's a good chance of their altered mental status. If it's sepsis, man, you just get to the hospital, get ALS moving. Infection of bloodstream, that is sepsis in a way, so that goes hand in hand. If they're hypothermic, you got to find out why. I mean, obviously, are they outside? Did they fall down? Did they fall asleep in the freezer? Why are they hypothermic? Um, and then slowly warm them and get medical control involved. And pneumonia, get them on oxygen and transport anyway. So you guys will get that. That list right there is, you're going to have that done in a couple seconds of getting on the scene. Abdominal pain and GI bleeding, yeah, that happens. And when that happens, it's not a good thing. So abdominal aortic aneurysm, um, that can cause some GI bleeding. Definitely, we've talked about that with other chapters in previous chapters. I think chapter 18 we covered it a little bit. Bowel obstruction or blockage, that does happen a lot with geriatric patients, and then it also happens quite frequently, and it will cause definitely some GI bleeding and diverticulitis, which is getting more common in my age bracket, even in the young 40s and 50s. Just little holes in their intestine, and seeds get caught in it, food gets caught in it, causes inflammation and then infection and just a horrible deal. Internal bleeding, um, I think that's interesting that that's even there. Internal bleeding would cause GI bleeding. Really? Yeah, it will. It makes sense. Um, Cancers of GI tract. Do see a lot of that with people that have colon cancer. They don't know it because they don't get checked, and then it gets worse. And next thing you know, they're bleeding, and that's how they find out. Ulcers, real common in my age bracket and down. I mean, let's face it. When you're my age and you got kids, you got a mortgage, you got a wife, you got all this career hitting you in the face, and it gets stressful and it creates ulcers. I've had my own stress-related health issues, not an ulcer, but I've seen a lot of ulcers in younger patients. So if it's in a younger patient, as you become a geriatric, it's going to be there. Adverse effects of medications. That's if you understand. Hopefully, you get the fact that that's an underlying theme from section to section of this chapter. Is you can never rule out adverse effects of medications in the geriatric patients. So, um, yeah, when you have these issues, these are some things that you want to assess for: abdominal aortic aneurysm, bowel obstruction, diverticulitis, and internal bleeding, cancer, ulcers, and adverse effects of medications. Um, when they're dizzy, weakness, and malaise. Now, malaise, for those you don't really know, that's just an overall not feeling good, just feeling horrible, and that's the only name they could find, really. Malaise. It's just the whole body system is feeling bad. They do not take complaints lightly. They can be associated with a number of serious conditions. Um, and I mean, any of those issues that we've already covered so far in this chapter can cause malaise. I mean, really, when I have a patient that they have all kinds of things wrong with them, um, I'll put malaise in the report because they just feel horrible because there's 50 things wrong with them. Um, Another one could be life threatening, absolutely, um, and be diligent in assessment. We got to really aggressively assess them for vague symptoms. Whatever you can find, it's a rabbit trail. Chase it down to you hopefully find something at the end of it, and you may not. So by the time you get to the hospital, you may not have an answer yet. I've taken people with dizzy, weakness, and malaise from the nursing homes. Find out later it was just a UTI, but UTI with you and I, no big deal. UTI with a geriatric, it can be a big deal, life threatening even. Um, this is an age bracket where suicide and depression can really hit. Typically, to be honest, the highest rate of suicide is with teenagers and my age bracket. Didn't necessarily with the older crowd. Now, with the older geriatric crowd, they may be depressed and suicidal, but they're not really going to do anything necessarily about it potentially. You just don't really hear about it a lot. But older adults can be caused by conditions that limit activity. They can't move, they can't do nothing. Health has just really got them down, so now they're just trapped to their recliner, watching TV, missing their family. It can be sad. Medications that sap energy. Now I will say this is, and this is just not a test purpose, but it's just me from what I've seen as medications that sap energy. Medication can suck it out of you, so you feel depressed and suicide. But there's also a lot of drugs that the side effect of it is suicidal tendencies. Um, and the truth of the matter is like I don't want to get into over a slide, but there's research that shows that there's drugs you see it on commercials that will say suicidal tendencies. It's in the bottles, but yeah, we don't ever talk about it. So then we put patients on it, and then when they go depressed, when they're not really, they haven't been depressed before the medication. So as EMTs, we can't do anything about that, but we can look at that as part of our assessment. Um, Let me see the bottles, read the bottles. If suicidal tendencies on there, depression or suicide, that's is something to consider in your not treatment, but you're going to treat the same, but you can also be a little bit more reassuring if that makes sense. Um, but medications can also sap energy. It can take it out of them, and and then make it worse. Loss of friends and spouses. They're at an age now where maybe their spouse passed away, their friends from life are passing away, and they know that their time is coming in the next little bit. It's just a time where you're at the end of your life, looking back, thinking, "Wow, my life is about done," and I can't imagine getting to that point. Biochemical imbalance. There you go. If there's chemical imbalances in the body, it can cause a depression and suicidal track. Um, so, just look at those things when you're taking care of these patients. And again, just be respectful. Um, Shingles, herpes, zoster virus reawakens after years, so appears as belt-like band around torso, scabs over after a few days, pain on side of torso. EMT can contract it from fluid, so fluid to fluid dust can give us that sickness. Falls. Death may result from complications of fall. They fall, they break, they get infected. Bruised ribs, cannot cough because of pain, develops pneumonia. There's exercises that people have to do if they break the ribs. There's exercises to get that tidal volume going. It hurts, but you're working your body to get that tidal volume. May indicate more serious problem: abnormal heart rhythm, stroke, internal bleeding. Assess for cause of fall as well as injuries from fall. Did they trip? Did they fall down the stairs? Were they dizzy before they fell? Were they hypoglycemic before they fell? Elder abuse and neglect. So ways in which older adults can be abused or neglected. Physically, psychologically, and financially. Um, they're at the age now where they're a burden to their family, um, and some family just can't take that. They're strapping them down financially. It costs so much to put them in a nursing home, so they get neglected. They get ignored. Life gets busy. Maybe not on purpose they get ignored, but life gets busy. You got day-to-day routines with your kids, sports, careers, school, um, church, whatever the case may be, and you know, it gets neglectful. It can be difficult to detect. Many states have laws that require reporting of suspicions. So, if you're suspecting something, now there's a difference. Okay, so there's a difference between just a busy family that hasn't been to see their parents at the nursing home, versus when you go in the house. Is it unkept? Is it unclean? Is it smelly? Is it full of disease? I mean, I don't know. It's you'd be surprised when you get in this field. You're going to see some horrific homes, um, that you can't believe anybody lives there. Well, note that in your report or in your mindset is: do you suspect abuse, and then does your what you're seeing match what you're thinking? Over time, one member of a couple often becomes a caregiver for a sick partner. Absolutely. If caregiver becomes sick or injured, their situation may become difficult or impossible. Um, Caregiver guilt or burnout. It's tough, when you're a caregiver of a spouse or loved one, it can burn you out, it can tap you out, it can get hard. But then when you're both down, it can get really hard. So you may need to make short term arrangements for the partner. So a lot of times you can help go up the ladder and say, hey, things aren't going good here, things are unclean, unkept, and, you know, put it in put it in a way where you might help make them arrangements to get rest and take care of each other. Um, the shingles rash can appear anywhere on the body. Ouch, poor guy. Um, Loss of independence. So this can lead to some issues, where they're help patient who is losing independence due to illness or injury. Um, and some people do. They lose not just their independence, they lose everything. Treat patient with dignity. Do not minimize fears and concerns. When they're afraid, they're afraid. Take it seriously for them. Look up, lock up house, not look up house. Sorry, lock up the house when you leave. Keep them everything safe. And these elderly patients, sometimes they get worried. Is my car locked? Is my house locked? Is my stove off? And you will at times have to care for their pets. Call the city, get them on board to help the pet situation out. Be reassuring and be empathetic. And like I said, I'm going to try to upload these videos for you so you can take a look at them. But anyway, any questions, concerns, text me. I'll get those videos uploaded to you. I appreciate you guys staying on track. We'll be back in the classroom in 1 week from today, and I'm going to try to post maybe one or two more classes up before that happens. And we'll talk to you guys soon.